All right. That's fine. Yeah.
Good afternoon, everyone. Welcome to our CCMB seminar series. I'm Yuma, Assistant Professor of Biostatistics and CCMB. And today I'm very honored to have Dr. Hamish Fraser to give us a talk at our seminar series. So Dr. Hamish Fraser is an Associate Professor of Medical Sciences from the Brown Center of Biomedical Informatics in the Division of Biology. And also medicine and the Department of Health Services Policy and Practice in the Brown University School of Public Health. So Dr. Fraser's research interests lie in the clinical use of machine learning models, including large language models, as well as biases and safety questions. He also conducts extensive global health research involving health information systems, data science, and AI and machine learning. Today, he will talk about can the diagnostic apps or large language models help patients diagnose and triage urgent or emergency conditions. So let's welcome Dr. Hamish Fraser.
Thank you for the introduction, and thanks for being here. Had lots of good conversations with people today, so I really enjoyed that. As the introduction explains, I have two major areas I work on, and so I decided to focus more on the symptom checker and diagnosis side of things, but I will touch on some of the global health stuff as well, which I had quite a lot of questions about, and I'm happy to discuss that further. So this is kind of building on some work I've been doing for a number of years, and we have recently had a lot of new experiments and some interesting new stuff, one of which just came in about 10 minutes ago, which is just an interesting example I'll show you about the sort of fun challenges with large language models in particular. Okay, so it's gonna didn't advance. Okay, like that. Plan B, good. So broadly speaking, I've been interested in the question of how do people diagnose problems when they're not in a kind of clinical or hospital setting. And over the years, especially the last decade or so, we've seen an increasing number of tools directed particularly at patients to help them to make diagnoses. They're usually called symptom checkers, and they've been sort of steadily improving in some cases over the last decade or so. And then, of course, in the last couple of years, large language models come along and provided all sorts of new interesting opportunities in this space. And so I'm going to look at those particularly. The story here really is that this is an example where technology is way, way beyond the evidence and the evaluation. So, you know, lots and lots of things are out there. Millions and millions of people use different kinds of online tools, particularly including symptom checkers every day. Lots of people, of course, more people use Dr. Google and things like that, but we really don't know whether these are actually useful or even safe. And so there's really not much evidence and also potential concerns about risks. And so, for example, Dr. Google is an interesting, I think we all, I'm sure, Google our symptoms sometimes. Certainly our patients in our studies do. And so, we see that we've also got these huge numbers of symptom checkers. So in 2014, there were already 100. Now there must be many hundreds of these systems, and millions of uses per month in the US, for example. Ada Health, the system I'm going to talk a lot about, grew from about 100,000 consults a year in 2017 to over 11 million 3 years ago, and of course more now. And we've certainly seen some studies that 50% of US adults use the internet as their primary source of health information. And this being the kind of field it is, that's obviously out of date. It's probably like 80%, or a very large proportion. And so we've also seen that, for us patients in the study in Rhode Island Hospital, 40% of participants said they would use the internet as their primary source. So this is very much something that people are doing. But then if you look at the one piece of good evidence here, and this is Dr. Levine from Bethesda Deaconess and Steve Malhotra, who's the new head of the Health Systems Policy and Practice Department at the School of Public Health. They were looking at people using basically Googling their symptoms. So they gave people simple case scenarios to read on. There were people recruited online. They read the scenario. They were asked to give their decision about what the diagnosis and what action they should take, if any, about this disease or problem. And then they were asked to go and Google their symptoms or use any online resources for a couple of hours and then come back and change their decision if they wanted to. And what they found, excitingly, was that the diagnosis went up by 5%, which is probably partially name recognition for the particular conditions. And there was absolutely no improvement in triage. So 2 hours of hard work and you still have no better idea on average whether you're going to choose medical care or stay home or whatever. So an interesting problem. So we all, if you Google, you really need to know what you're doing. So one of the early pioneers in this was actually a UK company called Babylon. They started around about 2016, I think. And around 2018, I'd done a very small study for Wired, looking at this in Ada and another system, and was very unimpressed with Babylon's system. So then they had this meeting in what's called the Royal College of Physicians in London. It's a bit like the Institute of Medicine, so very prestigious. Lots of famous people were there. The CEO gets up and tells everyone, we have a system that's better at diagnosing than primary care doctors. And so there's lots of excitement about that. And then people start to look at this, and they had released a paper, unreviewed paper, kind of a preprint. And so we had a wee look at that, and it was really bad. The evidence was very unclear. They cherry-picked cases from the kind of examinations for primary care, ignored the ones that were hard. Their system got to have 3 tries, but the doctors only got to have 1 try. All sorts of basic stuff. So we wrote a little letter in the Lancet, which was very carefully worded because they had a lot of lawyers and they like to use them a lot. But we pointed out this was really not very good, and that Babylon's study doesn't offer convincing evidence that its Babylon diagnostic and triage system can perform better than doctors in any realistic situation. And there's a possibility, likelihood, they might perform significantly worse. So anyway, this didn't luckily involve us getting sued. And we talked a lot about some of the frameworks we should really use to improve the way that people actually evaluate these systems. This is a study which is also from Dr. Marotra's group back in 2015. And so it's really kind of the seminal study of how do you look at these symptom checks. Oh yeah. Can I get that? Thanks. Yeah. Oh, thank you. So this study actually got a bunch of case vignettes that they created, which are similar to clinical problems. They had research assistant enter this data into the various symptom checkers. They found 23 that were publicly available. And then they tried to look at the diagnostic accuracy and also triage accuracy. And what they found was that the performance wasn't all that great. Still not moving forward, hang on. Okay. On average, the first diagnosis correct in 34%, top 3 in 50%, and top 20, so really got a lot of cases in 58%. And only 57% had appropriate triage. But what's interesting is that they were better on emergency cases and not good at all on home care, which I suppose is slightly better. But also that there was really very little kind of clarity about, some systems were very bad, some people were significantly better, but you couldn't really tell from using them. They also provided the same vignettes online to a group of physicians who were interested in diagnosis, and they came up with a performance of about 85% accuracy, so a little bit better, but not hugely better than the best symptom checkers. So when we start to think about these, one of the ways I often look at this is using a log frame, which is essentially originally developed for international development, but it's a very useful way of looking at some of the systems that we develop and deploy. So you start off with the inputs to the system, the activities that it carries out, the output, which is display, decision support, could be an alert or something. And then the outcome is a change in behavior. In this case, patient behavior, it could be physician behavior or the health system's activities. And then impact is when you actually see an improvement in patients' health and mortality. And so we tend to see that not a lot of these boxes are filled. So these ones are. The output may be good, it may not, but then we often have no idea what's going on here. And so with our symptom checkers, we're looking at the sort of different factors that were collected, usually demographics and just risk factors and symptoms. That's, the activities are, these algorithms they use. They display usually a list of diagnoses and triage, varies in different ways. And then the question is, do people change their plan for healthcare seeking behavior? and does that actually change their outcomes? And as you can see, there's a lot of different things going on here. This is more the data science and computer science piece. This is very much kind of a looking at the usability and decision-making processes. And then, you know, at this stage, you could look at whether the system actually has an impact on clinical care. So it's more of a clinical trial type of setting. One of the symptom checkers that was developed actually in Boston was called Buoy, or I call it Boy, it's British. That system just actually published this letter in JAMA Network for looking at 158,000 encounters. And they also had this idea of giving the people a survey, asking them to comment on that, on what they would do when they about a particular problem they had. They saw the output, and then they asked them again, what would you do after you've seen the output? And they found that this changed their behavior quite a bit, or their claimed behavior, I should say, with, you know, a huge proportion actually saying that they would be less likely to seek care, 30%. And so that was really a bit of a concern. And so we didn't know, no evidence was provided as to whether this was a good thing or a bad thing, what the output was or anything. So the people clearly are saying they would change their behavior in the response to these apps. And this is looking at another study which we did with the Ada, the company, and they looked at both the percentage of safe advice and then also coverage. So how many of the different kinds of problems, clinical problems it covered. And so they're all over the place. So Babylon actually did reasonably well on this one. But, you know, it was a very big variations in performance. And so we came up with some research questions, really. So can patients presenting with an urgent clinical problem effectively record their symptoms? So, I mean, are they actually able to use these things well? And did they find the Ada app easy to use? Do patient characteristics affect the patient's successful use? Were the diagnoses just by Ada as sensitive as the ED physician's diagnosis when we studied the system in the Rhode Island Hospital ED? And then we also gave clinicians just the data collected by the thing, and we wanted to compare them as sort of algorithms assessing that data. And then were the diagnosis and triage suggestions by Ada considered reasonable by the physicians? So they then viewed those. And did access to the vital sign data improve diagnostic performance as well? We're interested to see if that would improve triage in particular, actually. And so I won't spend too much time on this, but we basically recruited a sample of English-speaking patients with urgent or emergency conditions in Rhode Island Hospital. And we then collected data on the Symptom Checkers diagnoses, and that was given to the research team, but not the patients. And then we looked at the independent physicians, the ED physician's evaluation when the patient was actually seen. And then we also had the critique of those outputs. So Ada is, as I said, one of the leading symptom checkers in Europe, used quite widely in the US as well. And a couple of things, it's generally higher on average in the performance measurements in the different studies, although I said they're not very rigorous studies. And it also asks more questions than most of the other symptom checkers. It has more of a chatbot kind of function, which is good for research because we also get better data and potentially more complete data from the patients. And it has recently passed certification. So it's actually a certified medical device in Europe, but none of them are actually assessed by the FDA yet in the US. So, yes.
Does it have access to electronic health records, or is it always starting from scratch?
It's starting from scratch, except when you sign up, it asks you your age, your sex, do you smoke, high blood pressure, diabetes, and if you're a woman, if you're pregnant. So there's a little bit of background data on that, and then it takes it from there. So very limited, which is a good question because there's a lot of available data that is not necessarily being fed to these systems. And so this is a basic outline. We had the patients came in, they weren't feeling well, obviously, they used the app. Those diagnoses were compared with the actual emergency department physician. And then also the 3 independent physicians looked at the data, and that was also compared. And so that gave us kind of an assessment framework for this, where we can compare the app's performance with the physicians using the same data as the app. And so just generally, you know, we had a reasonable mix of patients, 65% female, 68% white, and a range of different characteristics in the ED. And I won't spend too much time on this because this is kind of really a sort of study we did a little earlier, but I want to kind of set the framework for the more recent work. And so we were able to look at the top 1, top 3, and top 5 diagnostic accuracies compared to the person who saw the patient. And if you have trained in medicine, people always say that the medical history is responsible for 60 to 7% of the diagnostic accuracy. And that seems to be realized in our studies, actually. And then we looked at this matches for physicians, and you could see that they came up with similar results. And this is the top one for the 3 physicians. And we can then look at the overall performance compared to them. So this is the initial study we did where we looked at 3 physicians and then Ada. And Ada does reasonably well. It's not as good on the top 1, but pretty close on the top 3. So reasonable results. And we also had some results where the physicians critique the output of the system. There were a handful of very unreasonable results, which were mostly diagnoses where the patient had put something different into the app than what they told the doctor. So this is a recognized problem that patients may say, well, I've got this app, I'll talk about my dermatology problem rather than that back pain I'm actually talking to the doctor about. So we have to kind of exclude those ones. So there weren't any really unexpected things there. The triage result was interesting. The overall agreement between the app and the physicians was 62%. 24% would say that it's safe but too cautious, so over triage. And then 14% unsafe and too risky, which probably overstates it. So in some cases, it was more like it was under triage, but it wasn't really unsafe. In some cases, it actually was unsafe, particularly for some of the other algorithms. So, it gave a reasonable result, but there were obviously some limitations there. And I won't go into the detail there, but a couple of other algorithms we looked at. We also did a user survey to see the usability of the system and what kind of ways that people search for information online. And so, for example, 83% had searched for medical symptoms and 28% had previously used a symptom checker. And this was using the technology acceptance model. So it's one of the standard ways we look at usability. It has 7 key questions on the usability aspect. Each of them also a 5-point Likert scale. And then if you take the top 2 categories, you can see a sort of a composite score here. And I should just mention that Ada Health provided a lot of technical support. They requested a review of the final paper for technical details of their actual system, but they had no other control over the study or the publication. So they've been a really good company to work with in that way because they're actually interested in seeing what the system does rather than trying to control that process. So we published that a couple of years ago, and then we started working on a larger study in primary care, which I'll talk about. But then, of course, ChatGPT came along. People started looking at it for diagnosis and looking for problems that hadn't maybe been diagnosed before, like this particular story online, and there are plenty others like that. So clearly, it was interesting to look at all these different things coming out. But what we had was an unusual data set because very few people had tried to have patients directly use a diagnosis tool and then come up with a final assessment of diagnosis and triage. So we were able to take that data, and of course, with large language model, it's kind of easy to enter the data. It's in the right format. So we were able to feed that into the system and then compare the performance of ChatGPT 3.5 and 4 on that data. And we also looked at the WebMD symptom checker, which is the most commonly used one in the US, and compare that performance as well for comparison. And this produced some interesting results. So Ada, again, down on the left-hand side, 3.5 did really well on diagnosis. 4 did worse on diagnosis. WebMD somewhere in the middle, and then these are the physicians here. So it was interesting the difference between 3.5 and 4. Got more interesting when we looked at triage, because in this case, the triage for 3.5 was really bad. So it has a 41% under triage rate. And in this case, it certainly was in some cases unsafe and too risky. Whereas 4 was a bit better. And Ada was doing reasonably well. So you can see that there was the strange disconnect between the diagnostic accuracy of 3.5, which was the best, and the triage accuracy was by far the worst. So that was an interesting point. And of course, it relates to the large language models not having a logical structure. So it can diagnose a myocardial infarction or a head injury, which it did, and then say, oh, don't worry about it, go see your doctor tomorrow. And so that's the real concern. So, we had this sort of sense, well, there's a lot of issues here. We wonder what's going to happen when we look at other data sets. Yes.
To understand the rationale of the study, I'm wondering about the prompts. Were you giving the data to the chatbots in a very like, here's the factual case, or are you trying to simulate what a patient would actually type, which is probably not very well organized? What is the thing?
So that was the idea of using Ada. So Ada has this fairly sophisticated history-taking chatbot function, which has been developed over a number of years, and it uses a kind of a Bayesian belief network kind of structure. So it asks sort of the question is most likely to produce the most information, and it does provide some temporal data and qualifications about severity of pain and that sort of thing. So that gave us a data set that the Ada app used, and we took that data set, which comes out as a list of some risk factors, the primary complaint, and then a list of symptoms present, symptoms absent, and unknown. So we basically entered the symptoms present, symptoms absent, and the demographics into, just copied them into ChatGPT, and then we provided a prompt to ask, for the diagnoses initially. And then once we started to work with 4, a little bit later, we discovered that the original prompt didn't work. It had changed its behavior. So when updated that, I was going to talk about that prompt. So basically, we were giving all the data that Ada had collected so that it was, able to then take it as an algorithm. I mean, there is evidence, I think, that ChatGPT can be made to do a history taking, and some people have managed to do that, but it's obviously not something the patients would probably be able to elicit from the machine system. Does that answer your question?
Yeah. Basically, there a question about sort of the intrinsic capability of 3.5 or to do the diagnosis with like a desktop and made for like a real world simulation. Basically, I just gave, maybe you showed the picture of the mother.
Yes. I think that's true, but in this case, we were sort of trying to control it so that if to get a sense of what the algorithm did on the same data, but with the proviso that you're right, that the question of how people interact with the system is a very real one. And actually, we'll come back to that with the prompts. So we moved on to primary care. We got some funding to do a study of 200 patients, actually 201, in urgent primary care, collected using the similar process, except that because it was during COVID, the patients had to actually click on a link, manage the consent using Ada and using the survey form at home on their own. So it was a little bit more realistic in terms of people managing at home, but a little bit more complicated as well. And so that we ended up recruiting 215 patients, but only about 201 actually had the full data from the survey and all of the different stages in there. So there was a significantly higher turn down rate. So of the 352 patients that were agreed to be enrolled in the study, only 201 ever completed it properly. So just similar to the previous one, we did have similar age range. It was actually a high proportion of women in this study because it's a women's health clinic. So it's 82% female and primarily. And so then a slightly lower, a high proportion of white patients. But otherwise, relatively similar results. Again, they were likely to use the smartphones and had general high technology experience. And so we then said, well, let's look at what the performance would be like with Ada and also ChatGPT, of course, on the primary care data. This is a poster we're going to present in a couple of months' time at AMIA. And so what we wanted to do was then to repeat the same study we did before, but with the primary care, take the Ada results, enter the data into ChatGPT 3.5 and 4. When we started to do this, we found that the prompt was really not working. And part of the problem was that it's very hard to get ChatGPT to offer home care because, there's a certain degree of maybe built-in mechanism there, not very strong, I think. But if you explicitly say, do you recommend patient stays at home, seeks routine medical care, or seeks urgent or emergency care, you can kind of push it into its corner and it'll give you some answers. One of the challenges with the triage side, though, was that most of these patients had already been triaged on the phone, so only a few of them really needed urgent care or home care. So that's a proviso. When we looked at the diagnostic accuracy, so ChatGPT really kind of pulled ahead a bit. In particular, WebMD seemed to fall off the cliff. I'm not quite sure why. We did the same thing in terms of the way we enter the data, but it is harder to enter data into WebMD. It doesn't have the same flexibility of, say, the large language model. But we can see with this performance on, especially on the top 5 diagnoses, that 3.5 and 4 were doing really pretty well. Ada was okay, but on the top 1, they were actually pretty similar, apart from WebMD. And so the ChatGPT was significantly more accurate on the top 5 diagnoses. So this was a question of how do we coax ChatGPT to actually list home care? So this is some of the things it came up with. In this case, it said, well, if your symptoms are mild, so I gave you some extra qualification. But then going forward, it started, when we adjusted the prompt, it would actually give us different levels. And in case it would come up with recommendations. Because clearly with these tools, if they're only going to give you routine care or emergency care, they're not going to be much use for people in the home setting who either ignore what it says or turn up at the ED. So when the triage side, however, with the proviso, I said that there wasn't as much in way of detail about urgent care and home care. ChatGPT 3.5 and 4 did pretty well. In particular, their rate of potentially unsafe triage, which is the orange one, for 4 was very low, although 4 had a higher over triage rate. So in this case, it pulled a little bit ahead of Ada and was significantly better in the under triage or unsafe triage. Because in the statistics, you can see there was actually statistical significant difference between, say, 3.5 and Ada and 4 and Ada. And WebMD was really doing pretty badly. So the question was then, to what extent, if we're using these symptom checkers, do they work with different patient groups? So obviously we have some concerns about the fact that, different patients may have different technology experience, different uses of technology. They may not be as clear about how to describe their symptoms as your point earlier. So we looked at the different characteristics of these patients, and then we looked at how those actually affected the usability scale score. So based on the 7 questions from the TAM usability questionnaire, we created an aggregate score, and then we used linear and logistic regression to look at that. So in this case, we're looking at the results of the technology acceptance model and combining the top 2, so agree and strongly agree. You'll see that the scores were fairly high here. They're not as high in primary care as they were in the ED study, which was interesting. It might be related to the fact that the primary care patients had to do a lot more work in terms of their getting the links and setting the thing up, as opposed to the ED patients who were given an iPad basically with the system on it. We also looked at regression and could see that there were a couple of these different categories, both in linear and regression. So age over 50 with an odds ratio of 0.4, and technology experience based upon an aggregate of questions about technology use, which also was significant. So these two are obviously related. You could see there was some relationship in the model between older age and technology experience, as you'd expect. But there wasn't any direct evidence for other factors affecting the way people use the system, which I thought was interesting. Obviously, we need to be doing some larger studies. And then just another way we looked at this question was, what if we tied different symptom checkers on a particularly acute problem, such as myocardial infarction or stroke? And could we try to see if the systems were safe and effective at managing these kind of conditions? So this is a study based on some data from earlier studies that we did on myocardial infarction diagnosis in the UK. One of the earliest ones was published in the 90s with a machine learning model, I have to say. So it was one of the early examples of that work. Didn't actually do a lot better than logistic regression because it was a kind of a linearly separable problem. So we took some of this data and we started developing models that might predict myocardial infarction based on patient history alone. This was a while back with some colleagues when I was working in Boston. So then we took this and we decided, let's take a sample of these patients and use 3 different symptom checkers, so Ada, Isabel, and WebMD, so 3 different systems, and then enter those cases into the system. We found that almost all cases, the symptom checkers diagnosed myocardial infarction and also unstable angina, so acute cardiac ischemia. So they seemed safe, whereas previous reports, particularly around the Babylon system, suggested that it was actually missing some cases of myocardial infarction. However, when we took the lowest risk sample of 29 patients who didn't have any kind of cardiac problem, were younger and very low risk, they also gave almost 100% diagnosis of myocardial infarction. So again, if you listen to this thing, it's not going to give you an answer to stay home. It's going to tell everybody they've got myocardial infarction. So we did also build a simple logistic regression model based on the data, and that was a little better at discriminating between these patients, but still suggests that while it could pick up patients with myocardial infarction, it could also have very high false positive rates. And so this was another example we were interested in. Could the systems can be used for patients with mild stroke or transient ischemic attack? And so we have a data set from Rhode Island Hospital that Tracy Madsen and colleagues have been working with over the years, which collects patients who presented with transient ischemic attacks, so it's like a mild, short-lived stroke, which turns out when you do detailed scans often is a mild stroke, in fact, but the symptoms recover quickly. And so the question was, could we actually get the systems to diagnose that? Because that might also be a very important example of helping patients to recognize a problem early on. And so in this case, we actually asked the system 3.5 about TIA stroke, and you can see it gives you some information about what you should do. And so you seem to have reasonably good answers. So we started to think about how to do a bigger study in this area. We had built an earlier machine learning model, which was actually just supervised learning based upon this data set. But the performance wasn't all that great, partly because there's not a very wide range of different diagnoses. It's mostly the two stroke and TIA and a few similar things. So the reason why this is so important for stroke is that it is this really serious medical emergency that if you get to a major center like Rhode Island Hospital quickly, you can get treatment with either thrombolysis or angioplasty, which can remove the blockage in the artery and actually restore almost all function. So it's an incredibly important treatment to get, but only something like 29% of people get to hospital quickly enough, and that's in a little state like Rhode Island. So, it's a really big problem for people to recognize this problem early and then be able to get to treatment quickly. So the question was, could we come up with a way of doing this that would help patients in the home setting? And we've been looking at a number of different areas. This data set with another one looking at more severe strokes, which we haven't really analyzed yet. And then Ada have actually collected, probably at this point, over 200,000 consults around the world with patients, one of whose diagnoses was either TIA or stroke. So we're going to be working with them to analyze the pattern of those patients. The problem is, of course, they don't know whether it was actually a stroke. Whereas in the case of the Rhode Island study, we have a very strongly validated diagnosis based on neuroimaging and a neurologist actually reviewing the case. So this is some early work looking at this data set with ChatGPT. And so results are actually pretty good in general, particularly with ChatGPT4. This is on 100 cases, a random sample out of the 1,400 or so patients. So you can see overall diagnosis of stroke or TA was there. About 5% of cases were unclear. The diagnosis wasn't clear. The diagnosis was wrong in a small number of patients. But the key thing here is to look at the rankings. So the top one is actually very similar to the primary care study. And then you can look at top three overall, 65%, 69%. But then you look at this situation here, and for some reason, ChatGPT, the GPT-4 API, with the exact same prompt and the exact same clinical data, and the exact same version, as far as we can tell, it's the same login, is 10% less accurate at the top 5 level. So one of the many fun things about ChatGPT is it's so hard to predict what it's going to do. So we haven't quite figured this out. There were some very minor differences in the way the prompt was written that in theory should have actually been better for GPT-4, I would have said, but we don't really know the answer here. And if we look at the example of these, this is the case. So these are the results from the ChatGPT version. And these are listing the different things. So transient ischemic attack and stroke are the two things we're particularly looking for. These ones marked in yellow are actually different in the GPT-4 output. So so you can see there's only about a 40 to 50% agreement of 56% agreement between the two outputs on almost exactly the same data within about a week of each other with the same prompt. So, you know, it's quite an interesting problem. And so as you can see, the performance wasn't quite as good on the GPT-4, but we don't really know why that is. And this is, I guess, is GPT-4 0.0 rather than 0, just to confuse everyone. This is a particularly interesting example. I actually just got this from Kenya, one of my students this afternoon, who's been looking at this problem. How do the performance of these systems change over time? So we have this one case in the ED of somebody who had a closed head injury, and the ED physician's diagnosis was either concussion or contusion of the brain or intracerebral hemorrhage. Fortunately, it wasn't as bad as that, but it was considered a closed head injury, and they were eventually able to discharge eventually, but clearly a patient that should not have just been left at home. So GPT 3.5 got the correct diagnosis, but decided to triage it as routine care. So that was one of the ones that we had in that first ED study. So a bit of a concern. It also did this with a myocardial infarction, and it also did the same thing with a patient with a severe kidney infection, all of which are potentially life-threatening diseases, obviously. So genuinely unsafe. But then when we look at GPT-4 in all its versions, it's unable to diagnose a head injury. So this is the latest 4.0 result. So migraine, temporal arteritis, which is a somewhat serious problem. So it did diagnose it, triage it as urgent. Cluster headaches, cervicogenic headaches. So this is not, again, not serious, and sinusitis. So only temporal arteritis would actually require any kind of urgent care, and it's not the correct diagnosis. The odd thing about this is that one of the symptoms of this patient is head injury. So an interesting puzzle. And he got it right the first time, but the wrong triage. And so you're seeing these good results on the primary care data, but you're thinking, well, what happens tomorrow? And do we know why this is happening? So we're trying to do different experiments with different kinds of prompts to go back and recheck the data. So clearly the algorithms keep changing. So we basically have to keep retesting to see if they're better or worse. So we don't know if the performance on the primary care data is better because of the data, because of the version of the algorithm, or some other factor. And another thing that people have seen, this is a study from Holland. They actually entered the same, these are ED cases that they extracted from the chart. They entered the same cases 3 times, and there was about a 60% agreement in the top diagnosis. The exact same case, the exact same day, entered 3 times. So that's also a wee bit of a concern. And then if we look at some of the other questions, this is some work done by Schmieding and his colleagues. It's got some really interesting ideas. They said, well, what happens if we just use Mechanical Turk and have people, again, read these case vignettes and then ask them for their opinion and compare that with the overall performance with the different symptom checkers? It turns out the patients are pretty much the same. They were better at diagnosing non-urgent problems than the symptom checkers, but they were worse at urgent problems. So in the general, the best symptom checkers, so Ada and a few others, are better than the patients or the lay people, but the other ones are not. And it gets worse because this is looking at the difference in 5 years between the original semi-grand study and this newer one that Schmieding did. And what they found there was that the performance triage levels in some cases went up, in some cases went down. And so there was no overall improvement over 5 years in the triage performance. So it was really kind of surprising what was happening there. And they looked at, these are more detailed, but basically what they're looking at was that the systems were generally better on emergency cases than patients. So some positive things there. I'm going to move on here from my colleague Ross Koppel that suggested that ChatGPT maybe appeared in Shakespeare. It's as if he didn't exist. Life's a tale told by an idiot, me, for instance, full of sound and fury, emotion and eloquence, but ultimately signifying nothing, utterly meaningless, null and void. That was from Macbeth, but perhaps a little harsh. I mean, we've got some better results than we had last year, but I think it's still a real concern where we are. And a little final note on Babylon. So they continued to grow they reached about 4.2 billion valuation. And then the next year they fell apart and went out of business. And so I think, while Babylon's a bit of a unique company, it was kind of interesting that they never really engaged with the medical profession. They were very aggressive. They never tried to kind of work with people who really needed the systems to do better research and so on. So, that might have been a bad thing for them. And I'm sure there were other reasons why this didn't work out, but it's interesting that it's not necessarily these sort of private AI companies building medical systems are not necessarily doing themselves any favors by not working with clinicians and patients and making the stuff work well. Okay, so I'm just going to briefly mention some of the work in global health informatics and then leave some time for questions. So I didn't really focus on this so much this time, so we had a little bit of time to talk about the symptom checkers and some of the new things we're finding. So a couple of things I'm doing at the moment. So this is, so Wazi, who's a PhD student here, is working with me, and we're looking at a study which we're doing with Joe Hogan in Biostats in Kenya. And there what we're doing is using machine learning models to predict patients who are lost to follow-up for HIV care. And so with HIV care, we've got pretty comprehensive and successful systems now for treating patients with the three classes of antiretroviral therapy. And if the patients stay on treatment, the outcomes are pretty good and people have, fairly good lifespan. But large numbers of patients miss some visits or actually become lost to follow-up. And that, because you need to have very continuous treatment, these patients are at increased risk of deterioration and death. So one of the ways that people have started to look at that is, can we predict which patients are higher risk of missing a patient visit, which correlates with being lost to follow-up? And so develops various different models using supervised machine learning approaches. And they can get reasonably good results. But what we've seen is that there's very little information about whether these type of models, actually any kind of AI system, works well in low and income countries. So although we're not the only people working on these prediction models, we seem to be the only people doing any kind of clinical evaluation. So what he's looking at a couple of things. One is this systematic review we've been doing to look for evidence of studies of use of AI, particularly machine learning, in low and middle income countries, where there's been a publication that actually includes a clinical evaluation in real patient settings. Primarily, we're looking for randomized controlled trials, but that's really not happening. So any kind of clinical study would be nice, but the numbers are minute. I mean, they basically fit on the fingers of one hand. There is one exception, which Adam Levine is one of the authors on, looking at models to predict diarrhea, positive diarrheal disease, where they actually did a randomized controlled trial in both Mali and Bangladesh, studying the use of this by physicians. It didn't, unfortunately, actually change patient behavior, well, patient treatment. And so there were interesting conclusions that the way the information was displayed, which was primarily, I think, a numeric score, meant that when they looked closely, the highest scores and the lowest scores did seem to be responded to, but the middle range, it's difficult for people to know what to do with that. So I think it's an example of this question of how does the interface potentially change patient care when you do have a good algorithm. So yes.
Did you look in other registries? Do you imagine these being interventional trials or observational trials or some mixture?
I'd take anything. I mean, their intervention is really what we need, because there are systems being deployed, like in Kenya, the other model for loss to follow-up prediction in the national EHR system is deployed all over the country, but there is no clinical evaluation at all.
So what is the intervention?
Oh, so what we're doing in Kenya is that when the clinics that are in the study receive a printout or an online list of the patients who are at high risk of loss to follow-up based upon the prediction model. And they then the treatment supporters then call those patients to find out if they're going to be able to make their appointment, and if not, can they reschedule the visit. And so it's a fairly simple intervention. We started with 1 day missed visit, but we're now moving on to 7 days, which makes a little bit more sense in terms of people's sort of overall behavior. What we can see at the moment is, and these are very preliminary studies of results, I should say, that the people who are likely to miss visit by 7 days, it's about 7% in some of the sites we're looking at. But the model predicts that the the prevalence of missed visits in the output of the model is about 35%. So it's increasing quite well the probability that the patient who's being called is actually one who's going to miss a visit. So in ways, it's actually more of a resource management tool at this point, helping us to focus on the people who are high at risk. And it does seem to be making a difference in terms of people's loss to follow up. So we're doing a step wedge cluster randomized controlled trial at the moment. So we hopefully get some results on that sometime next year. But so Wesley's been looking at this, and also he's going to be looking at sorry, this is actually the abstract that we published on the systematic review last year. Also going to be looking at this question of, can we look at the use of LLMs for this loss to follow-up prediction? Because although there are lots of reasons why this might not be a good idea in a low-income setting, people are using them a lot because, of course, they're very easy to use. So we're interested in whether these tools do work. And also there's some real concerns about generalizability with the machine learning models, the supervised models we've been using. They're very specific to particular clinics and particular populations. So you're going to be, if you're going to do this successfully, you're likely to be retraining these models a lot, which is really not something that's easy to do. We have a unique environment with the OpenOS electronic health record system, which we are able to manage all the data and implement the systems so that we can track each patient's, when they turn up to visits, whether the patient was called, all the kind of actions, and compare that. So we're going to see, hopefully, if large language models might be better at generalizing to different sites, or they might not, and also think about things like resource use and whether, for example, open source models installed in Kenya might be a viable option, because I don't think ChatGPT is. Another thing that I call out is, this is Victor Hunt, who is a medical student here, and he is a Global Health Informatics Fellow. And this is a fellowship program which we started in the last year for medical students in the end of second or third year, interested in global health informatics projects and studying the ways in which we can improve quality of care. And so Victor's actually looking at care in Costa Rica and some of the problems in smaller clinics, particularly private clinics in Costa Rica. So we're looking at ways of improving that and the kind of EHR systems that they have available and how they might be used more effectively. Okay, so any questions?
Thank you for the wonderful talk. I have two questions. The first question is, I'm curious for the system checker, does it contain any like self-test results? For example, like COVID-19, a faster test, is there contain that kind of results to be incorporated in your study?
It would be a good idea. You know, I think it's interesting that this is a field where you can see that because it's primarily commercial organizations, they haven't really integrated well with the available data. So there are organizations that actually use symptom checkers as sort of part of their patient triage systems, but they don't seem to be feeding any kind of data to the symptom checker, which should be the obvious thing. So algorithms that would incorporate previous diagnoses and also medications could really improve the accuracy, I think, of diagnosis and potentially triage as well. But we haven't seen that. So it's something we're looking at. So in the primary care study, we haven't looked at this yet, but we did collect medication data. And we're also we had the physicians who review the cases also comment on the quality of the history taking and whether there were any additional questions they would ask. And so about 2/3 of the cases, only one of the three or no physicians suggested anything additional. So it looked like the history taking was reasonable, but in the 30%, some of those obviously were missing things. So we're still trying to understand this question of how do you get the most comprehensive data available and then use that. And so none of the systems that I'm aware of them that are available commercially will actually take medication data or link to EHR data, which they should. Yes.
What do you think is a good payment or incentive model for deploying symptom checkers or other AI systems?
Really good question. So I'm sure that is one of the reasons why Babylon went belly up, because they didn't really think this out. So for a while, the symptom checker companies were working with insurance companies and trying to come up with sort of models to help patients be managed better in the home setting. But they weren't able to prove that, partly because they hadn't done any studies, And so I think that has not really moved forward. I mean, one obvious model is, in fact, to work with a health system and to incorporate a triage tool in the health system's system, maybe urgent primary care or, patients calling in for care, where they use an algorithm. And there are examples of that, where people are experimenting with that.
So the health system would pay the company
Yeah, I think
based
so.
on
Based on better triaging patients to manage them so that they got more of the patients who need to come in emergency and less patients who didn't need to come in. Now, that second piece, the less patients who don't need to come in, seems to be a problem. So no one seems very good at discriminating against about patients who have mild, non-threatening problems. So like we saw with the chest pain. So this is
which is where the most sort of savings.
exactly. So where the financial model might be. Now, on the other hand, I'm kind of optimistic that we may do something good with stroke, because myocardial infarction is tricky, because although chest pain is, and if it goes to your left arm and certain characteristics can be somewhat diagnostic, a lot of the symptoms like exhaustion, sweating, nausea, etc., are very, obviously common symptoms. But with stroke, nearly everything is weird. You have weakness you didn't expect, you have double vision, you lose your ability to speak. There's a lot of things that you wouldn't see normally in your life. So I think, although people seem very bad at diagnosing stroke in general, I think algorithms are much better. I think we're kind of seeing that.
There, in that context, is it reasonable to say the insurance company should pay, because if the stroke is diagnosed quickly, the medical costs for the insurance company are substantially reduced?
I mean, I think it would obviously be a really good thing in general, but yes, I would actually save the company and certainly save the patient enormous amounts of resources if they were back to their normal self rather than dependent. So it's interesting. The model is not that clear, but then, we have hundreds of millions, billions of dollars being spent on AI speculatively in the thought that will then suddenly be incorporated in medical care. Now, in radiology, it obviously is being incorporated, and so those companies presumably have a business model. But whether it's a good business model long term, I don't know.
And I think in that context, insurance.
They probably would. I mean, if you're not missing a mammogram, showing early stage cancer, then that AI would probably be a good thing. And we've seen some evidence suggests that's the case. Other questions? Yes.
There's definitely some notable examples of that, and being very confident in reporting. And so I can imagine like online tools was always taking that a prediction, but maybe some of these tools are developing thresholds or confidence scores for determining results, such that maybe results with information people provide might not always get a diagnosis, or you might get a diagnosis that's related to the pre-diagnosis.
They don't seem to have a very good way of handling this. So one of the notable things in a study we did with like 200 case vignettes with 8 symptom checkers, which included Babylon and Ada, was that Babylon, about 50% of the time when the study was done, it didn't have an answer for certain kinds of conditions. So it just said, sorry. So a lot of common things, you put it in and just said, sorry, or no answer or something. I suppose that's honest, but it wasn't all that helpful, given that the others would do that. In other cases, I mean, Ada tends to try and structure things by probability. So it might have some serious condition, but it might be considered 1 in 1,000 chance. The calibration of those probabilities, however, is a little suspect. So we treat them just as 5 diagnoses and do the top 1, 3, 5 on that. So it is, I mean, you're right, it's a problem. Now, the alternative is, for example, WebMD was a study looking at ophthalmology cases, and they looked at both mild and severe conditions, so sight-threatening conditions like acute glaucoma or detached retina. And it was really bad at picking up the serious conditions. So only 40% of the time did it actually identify the serious condition and the fact they needed emergency care. But I don't see any sign that they took that piece of it off the market, or it says, sorry, I'm not good at eyes, which is what it should be doing, right? You should be putting a sign up saying, no, not ready, under construction when you try and put in information about eye problems. But we're not seeing that. So there's no real structure here, right? There's no sort of incentives to do this right. And I think it's what's really interesting. We see so much discussion about how regulation cramps innovation, but actually smart regulation is essential for innovation, because we're still seeing these symptom checkers on the market 5-10 years after they're released that are really terrible. And they've never improved them because nobody made them. So you could see they were still getting 30% accuracy when the best ones were at 70%. So if you put regulations in like they're doing in Europe, and you actually have to pass, proper device regulation, it's going to boot out a lot of the worst players, and you're going to get something better. So I think that's one of the challenges here. We need a system that does that. Oh, somebody raised their hand, I think.
Oh, hi, Hamish. This is here Sanjay Mishra. I'm attending it through Zoom.
Okay.
So my question was in the latest that I think of was there was a study in 2021 that came out. It was on preprint before, where they looked up into these models, especially EDA was one of them, and they looked another a dozen of those. And they found in the European and North American countries that the top 5 predicted conditions were not as high as 50%. First question is that has anybody benchmarked them since then with the ChatGPT? And I apologize if you already covered it because I joined a little later. Has they improved over the last 2 to 3 years since these new transformer-based models have come up? Or is it still just a hit or miss of 50-51%?
Well, I've talked around the question, but not exactly that. I think that you're right that there doesn't seem to have been a lot of movement. Now, what we don't actually know, and this is a bit of a challenge with ADA, is that the ED study we did originally was in 2018. So the ADA algorithm is from 2018, whereas ChatGPT was 2023. And also WebMD was much more recent. And so that's become an issue because it's not clear how to re-enter the data into a system like ADA, because the chatbot doesn't allow you to really put the same symptoms in exactly the same way. So we tried that, but it got sort of similar performance before, but it's probably not a good test. So we are going to start recruiting patients, hopefully, with now all the data use agreements are out of the way, in the next 2 or 3 weeks in the ED Rhode Island Hospital with the latest version of ADA. And so we should hopefully get some better data on some of these questions. But I mean, I think your point is good that we, it's quite variable depending on which study you look at, and without using real patients actually being seen in an emergency department or urgent care, I don't think you can give much of an estimate of how it really works in the real world. I mean, there is one study from the ADA team, which they did in Germany with 378 patients, looking at triage accuracy, and they came out with pretty good triage accuracy. That was run by the company itself, but I think it's not far off the estimate we got. So I think, particularly triage is a particular question, of course, in an emergency patient situation. And when you look in the details, those that are sort of considered either unsafe or too low triage, many of them will probably be okay, but some, and certainly some of the cases we discussed here, would actually be in danger if they have myocardial function and they're triaged as routine care, for example. So it's a tricky question to answer, but basically there's not a lot of data, though it's getting a little bit better.
Thanks.
Any other questions?
No questions. Let's thank Dr. Hamish Fraser again.
Yes.
Please feel free to reach out if you have follow-up questions. Thank you.
Should I turn off the Zoom? Just turn off Zoom.
Yeah, you can just press leave.